In November 2007, Kimberly Quaid and her husband Dennis welcomed their newborn twins Zoe Grace and Thomas Boone into the world. Unfortunately, 2 weeks after their birth, the babies developed staph infections. The infections were difficult, but the treatment method was relatively standard and included administering an appropriate sized dose of heparin, a blood thinning medication. Unfortunately, the wrong dosage was given to the Quaid infants by 1,000 times. The pharmacy technicians administered adult concentrations of the drug to the pediatric unit. The infants were administered 2 doses of the drug 8 hours apart. Then, when the Quaids were called to the hospital to check on their condition, they were told that the babies were fine. What the Quaids did not know was that the hospital was treating their babies for the overdose, which left the babies vulnerable to extreme bleeding. The Quaids were not made aware until they showed up at the hospital early the next morning, greeted by the risk management department, and were finally told that their children were in critical condition. To make matters worse, the hospital also mismanaged media relations. Fortunately, after 11 days in intensive care, the twins made a full recovery. The Quaid family settled the case with the hospital for $750,000, and the hospital was charged an additional $25,000 by the California Department of Public Health.
There are three components that are required of a medical malpractice case to be effective. 1. A patient suffered an adverse event. 2. A medical provider is responsible for the event due to action or lack thereof. 3. This provider was negligent, meaning that the provider took less care than that which is regularly practiced. Thus, the significance of medical malpractice system is twofold. First, to compensate patients that are victim to negligent health care, and second, to discourage physicians from practicing negligent health care. Medical malpractice litigation, as Americans recognize it today, was not an established phenomenon until the 1850s. This is largely due to the rise of marketplace professionalism, a phenomenon that is unique to the U.S. So during the 1830s, a number of elite sectors of American life came under intense scrutiny during the extreme anti-monopoly sentiment of that decade. Eventually, as this movement became more popular, no United States state government was willing to sanction one group of potential professionals while excluding others. Consequently, physicians found themselves in a competitive market, which included a wide spectrum of untrained healers and trained physicians. Also with this movement, just as anybody could practice medicine, anyone could also practice law, and so grew the amount of suits for malpractice. Interestingly, American courts encouraged this trend by relaxing the standards for initiating civil tort proceedings, which includes medical malpractice. According to the JAMA Network, from 1840 to 1860, the number of malpractice cases carried to state appellate courts in the U.S. as a whole roared ahead 950%. The population rose about 85% during that period, which suggests that the rate of malpractice suits jumped abruptly by a factor of roughly tenfold during the middle 2 decades of the 19th century. As lawsuits continued to increase, not only on untrained physicians but trained physicians as well, this revealed one of the most crucial points that explains why malpractice litigation originated in this area. That is that there can be no malpractice without established practice. In other words, physicians cannot be convicted of deviating from accepted standards if there are no accepted standards to deviate from in the first place. What this means is that amateur physicians and healers had no fixed standards or manual, and that they made a virtue of treating each case individually. On the other hand, educated physicians have texts and advanced manuals that were used against them in court as systematic norms that they were accused of deviating from. Physicians then, rightfully bitter, believed that the general public would not be attacking them, the physicians who helped them, if it weren't for corrupt and professionally irresponsible attorneys. So this essentially explains the origins of medical malpractice litigation. Next, we will explore the expansion and perpetuation of the entire system. When it comes to the perpetuation and expansion of malpractice litigation, there are two sides that we must address. First, the medical argument, and second, the legal arguments. In short, among the medical explanation, there are three propositions that stand out. First, the competitive nature of the U.S. medical marketplace has driven an ideology of continuous improvement and medical innovations. However, these innovations are often associated with increased risk. For example, the X-ray technology absolutely advanced medicine. However, litigation concerning radiographs produced many of the highest damage awards within malpractice cases. A second medical explanation for the growth of malpractice litigation speaks to the necessity for standards against which measures to take, as mentioned earlier. The American Medical Association was founded in 1847 in response to the rise in medical malpractice litigation. As the AMA made strict licensing laws and established uniform national standards, this also gave lawyers more legal grounds to sue physicians. A third argument speaks to the advent of liability insurance that is now required for physicians. In short, this insurance allows for risk to be dispersed through the community, and physicians no longer face the risk of personal bankruptcy. Now, among the legal arguments, there are three principal propositions that explain the persistence and growth of malpractice litigation. First is the contingent fee arrangement. Under this arrangement, there was no risk for plaintiffs to file charges. Plaintiffs could then split with their attorneys a proportion of any settlement they were able to win, inside or outside of the courts. A second explanation argues that medical malpractice cases are tried before ordinary juries that are largely unable to assess the fundamental aspects of evidence in front of them. The third explanation speaks to the nature of the nation's system of tort pleadings. The JAMA Network states, American legal theory defines torts broadly but vaguely as private civil wrongs that violate understood duties or social responsibilities. Torts differ from contracts because the parties to a contract have theoretically agreed in advance on acceptable and unacceptable outcomes. Hence, the nature of torts are that they are vague, flexible, easily manipulated, and easy to initiate. All right, what do you think are the current problems with the medical malpractice liability system?
I think there are two extreme views about that. One group of people, they think that the current system is good, whereas other people think that this is totally wrong, and doctors and medical professions are at very high risk. But we must bring the system somewhere in the middle where the patient's rights are also preserved, but at the same time, there should not be a lot of frivolous lawsuits which are currently in practice.
So, from your personal experience, what steps do you think that the government can take in terms of medical malpractice reform to create a more justifiable system?
I think there are different states have different laws, and I personally think that states like Indiana probably are doing a better job because they limit. The purpose of suing is not to have a monetary kind of a damage, but it is to prevent and protect the patient's rights. But here, the frivolous lawsuits, the doctors end up losing everything. So in Indiana, for instance, there's a limit that you can, if you sue a doctor, they you'll be penalized for a certain amount. Not you would not exceed that you don't lose your lifetime earning and everything. So I think that system has to be, followed better.
As Friedman describes, tort law is implicated based upon a set of rights defining what acts are and are not wrongful. Tort law is based upon determining the cost that wrongful acts impose on others and the degree to which they should be held liable. This includes both the actual damage and the reciprocation of externalities. Therefore, it is not realistic to presume that all risks can be eliminated. Rather, an efficient system of precaution must be established. When analyzing the tort reform methods that would be the most common, the overwhelming example within the field of healthcare is the idea of negligence. As Friedman describes, economic negligence can be defined by using the hand formula. A party is negligent if there is a precaution he could have taken to reduce the probability of the accident such that the precaution was less than the reduction in probability times the cost of the accident. In essence, the theory of negligence is that a party must take the necessary level of precaution that a truly rational individual would pursue. There are two sides of precautions, observable and unobservable. And within the field of medicine, the majority of the most influential precautions are going to be unobservable. However, as has been discussed within the medical industry, it is difficult to know where this level of equilibrium lies. The medical malpractice system as we know it today fails to accomplish its agenda. Instead of promoting the interests of both physicians and patients, the system fails to compensate those who have suffered from poor medical care while compensating patients who have not. Decades of negligent care have created an insurance market within the field of healthcare. Thus, because physicians live under constant supervision and their actions are integral to the health of their patients, physicians have an incentive to be insured. However, the degree to this question is subjective, and the question arises of the degree to which physicians should be held accountable within their practice. Physicians are subjected to unparalleled scrutiny within an insurance system that is dominated by lawyers and third-party members attempting to accrue a profit. This is the reasoning behind defensive medicine, in which doctors and medical staff take unnecessary steps in order to avoid being sued. This shifts the focus of providing the best possible care to physicians being unnecessarily thorough. This could mean that physicians take unnecessary preliminary steps during their practice, which could cause serious health repercussions to the patients and increase the physician's dependency on expensive pharmaceuticals. Additionally, on the other side of the situation, the patient must be reassured that they are receiving the best care possible. This theory is best analyzed when considering Pareto efficiency within the market for healthcare. Within the industry, the ideal situation is one in which all physicians and patients are made better off, with no one being made worse off. This would allow physicians to practice freely and work in the best interest for their patients. However, there is no true economically efficient model when analyzing reform methods. The jurisdiction must lie somewhere, and the majority of the time it falls in the hands of physicians. It is far easier to blame the person with all the knowledge than to hold the patient accountable for their ability to get better. This introduces one of the broad market failures that impacts the healthcare industry, the idea of imperfect information. There is no possibility for there to be perfectly available information, from either the doctor's perspective or the patient's. The patient is never going to be able to know the best method that will work for an individual patient, simply because every case is different. Furthermore, patients never know the true extent of their own condition, and certainly don't have the capacity of medical knowledge to properly address their own case. This could lead to situations where physicians could theoretically take advantage of their patients' lack of information and charge them for additional care that would otherwise be considered unnecessary. One possible method of tort reform is developing a system of collective accountability. This system would allow hospitals and primary care institutions to hold the primary jurisdiction within the healthcare system. Ideally, this would allow for a cap to be placed on the amount that physicians could be sued within a malpractice situation. Therefore, by limiting the amount of damage on the physician's side, then they would not take unnecessary steps to provide increased medical care. This theory is based upon the idea that the majority of errors occur for patients are due to systematic errors in their system and are not to be blamed on the physician. Furthermore, this reform would allow for proper distribution of resources, as hospitals and physicians would be able to provide a wider variety of services without being limited to a single provider. However, this method is dependent on the proper establishment of the insurance market. If physicians cannot be sued at an extreme rate, then they must be able to still provide the necessary level of care needed for patients to get better.